Hi, everyone. I'm going to go ahead and get started here. My name is Grace Huang. I am an associate professor of medicine at Harvard Medical School. I serve a variety of faculty development roles, and one of those things is working with faculty and trainees about their educational projects. I also have a hat as editor-in-chief of Med Portal. Med Portal, if you're not already familiar with it, is a journal published by the Association of American Medical Colleges. It focuses on publishing medical education and dental education materials, and as part of that journal, I look at a lot of projects and how they are evaluated. I'm very excited to be here today to talk in the webinar, and what I encourage you to do is to use the chat function to ask questions as we go along. I believe right now all the attendees are currently muted, and so if you have any questions, I can definitely see them through the text function. We'll also leave some time at the very end of the session for open-ended questions. So I will try to leave about 10 minutes free to answer your questions. So I'm going to go ahead and get started, and I also want to thank RSNA for hosting me for this session today. Just to give you a sense of what we'll be covering today, this is intended to be really the briefest review of educational measurement. I don't expect that at the very end of this session that you'll be experts in it. In many ways, it's hard to do educational evaluation and study it from a disembodied place. It really is when you're doing the work of the project itself. But what I do hope to do is sort of awaken those inner parts of your brain that may have remembered what it means to evaluate educational work and even some of the statistical things that I will cover. Overall, my goal is to empower you to learn more and to give you some resources to know where to look for this information. It's either maybe a source of encouragement or discouragement that I learned everything on my own. I don't have an MPH, I don't have a particular master's in evaluating in particular. So all of this I learned on the web and working with mentors and with other individuals in projects. So. The other thing I wanted to mention is with the webinar format, I'm going to have a couple of what I call Blue's Clues moments. If any of you have kids that watch this show, they found that a show like Blue's Clues was very effective because there are built-in pauses in the middle of the session that allow the watchers to answer questions. So I will pause a little bit for you to answer your own questions that I pose. And it's not intended for dramatic effect, but really for you to think about the work. So in terms of the objectives, we're going to cover three main areas. What I hope that you will get out of this is a sense that there are many frameworks out there that provide the scaffold for how you should evaluate your educational project. The second thing is that we will cover study designs in educational research. They do not tend to be the ones that we see that are hardcore in the biomedical paradigm. The pre-post designs, for instance, are very common. And I'll go through the pros and cons of using one study design over another. Thirdly, we will just briefly touch on statistical tests. You can learn how to do this without paying for a large statistical software. You may not come away from this webinar immediately able to do it, but I do want to give you the sense that there are tools at your disposal so that you can do this on your own and perhaps practice. So a couple of ground rules. The first of all is that our focus will be on evaluation of educational projects. I won't be talking about clinical research, obviously, and I won't be talking about all these other elements simply because it is not within our time frame. There are workshops and even courses on how to design instruments, and by instrument, I refer to data collection methods like a survey or an interview tool. I won't be going in depth about validity testing, which is essentially to get a sense of how good your data collection instrument is at measuring what it's intended to measure. This is obviously not a statistics course. I'm obviously not a statistician, but I will touch on some statistical tests that you may or may not have heard of in your past. We won't have the time to go over power calculations. Please do recognize that they are a very important calculus to do before you start a project, so you get a sense of what kind of sample size is needed to meaningfully demonstrate change. And then lastly, I know that this seminar series is about educational scholarship. For the purposes of this, we will not be talking about what does happen to be my favorite topic, which is publishing. The second thing is that there is terminology. I use the term evaluation in a very broad sense for the purposes of this webinar. If you look at the word itself, inside of it is the term value. And when I say to attach a value to, I mean getting a sense of how effective your project is. You may connote evaluation with things like resident evaluations or teaching evaluations, and I kind of want to separate that. When I talk about evaluation, I will be talking simply about what it means to demonstrate the impact of your educational project, not how to fill out an evaluation or things like that. So I want to start with a sample scenario. This will be the theme that we use in carrying out the rest of this webinar. And so the prime question for us today is, you have an educational project, and how do you plan to evaluate it? So here's a kind of scenario that may be common to residency educators and across undergraduate medical education, graduate medical education, and faculty development. This is the topic of quality improvement and patient safety. So let's say that you would like to evaluate a curriculum that you've put into place to teach radiology residents about QI and patient safety. So that will essentially serve as the backdrop for what we'll be doing. I hope that this example resonates with you, because curriculum evaluation is most likely the most common type of educational evaluation that you're doing. That being said, there are also opportunities for educational research or development of work, validity of instruments that may be also educational projects that you're involved with. However, for the purpose of today, we'll be talking about how to evaluate a curriculum. So some of this is about how much work you're willing to put in beforehand and then afterwards. Essentially, what is post hoc and what is a priori. Definitely understand that I have fallen into the trap of trying to be opportunistic, where I've put in my curriculum in place. I don't have the time or energy to think about evaluation, and I would say that I've been burned several times by that. So what I do encourage you to do is to move away from the temptation to wait until the very last minute to evaluate something. It's very hard, I think, to cobble an evaluation schema together after you've already set sail. What you should consider are the following steps. So, like I said, I have fallen so many times into the trap of waiting at the last minute to think about evaluation. This is almost universal among our educators. And then what I do is end up throwing together measurements just for the sake of measurement. An a priori approach to evaluation means that you would think about how you should evaluate an educational project based on the objectives that you have for your curriculum. That you would consider things like sample size and your power considerations. That you put some time into thinking about how you should develop your instruments in a methodical manner, and then getting IRB approval. The issues with sort of skipping some intentionality around designing your evaluation beforehand is you'll get what I've gotten before, which is instruments that don't work the way that you want them to, negative results which may be due to poor sample size or questions that are not sensitive to pick up the impact of your curriculum, and fundamentally that makes it very hard to publish your work. While publishing is not the end-all and be-all, it is something that allows you to get public acknowledgement for what you've done. So I do think that it is important in your careers to think about how you publish and disseminate the educational work that you're doing. So we'll go through a series of questions that are intended to bring you through how I think about educational evaluation. The very first question is, straightforward. Why am I even bothering to measure the impact of my curriculum? Here are some possible answers. The first is that you may want some individual performance feedback on what you're doing. So, for instance, say you want to put into a curriculum your patient safety and QI principles. Sometimes it's just getting a sense, oh, how well are my residents performing in this area? The ACG cares about this, and I want to get a sense of what I could do better to teach them this principle. This is where feedback is intended to be very formative, sort of ongoing, informal, how can I tweak this lecture? How can I tweak these materials? And so that would be an example of feedback on individual performance of those learners. Evaluation, as we mentioned, value, the value statement is part of this, is getting a sense, okay, how could I judge the performance of my residents on QI and patient safety principles? Taking it to the next level, you may want to get either feedback or evaluation on the program itself. So let's say your curriculum on QI and patient safety is in the purview of your chief medical officer who wants the entire institution to really take it up a notch in terms of what they understand about QI. And so therefore, your program is the centerpiece for why you are doing this evaluation. Justification of your existence can look like a variety of different ways. It may be that you have a patient safety or QI position, and this is part of your job description. It may be that this is part of your niche, and so evaluation lends credence to what you're doing, because in a systematic way, you're collecting information about the curriculum that you've put into place. As I mentioned before, the ACG&E, the LCME, many different organizations care a lot about this kind of content. And so you may be evaluating it to meet those requirements and to demonstrate that you've done something substantively. And then lastly, and perhaps this is actually your first reason, is that you would like to get some credit for what you've done, to share your work out there and possibly use this as some kind of evidence for why you should be promoted. The next question that you should think about when asking, oh, why am I bothering to evaluate my work, is what resources do I have? You can see that this is very much trying to think about the practicalities of what you could measure. I think about this in several different domains. So I'm a very much a low-hanging fruit type of person, so I want to get a sense, what's already available to me in terms of existing data sets? And that may be, perhaps I already have questions in my evaluation system that look at how residents are performing in QI and patient safety. Great not to have to reinvent the wheel. I might be able to use those data already. There may be similar institutional surveys about patient safety knowledge or the patient safety culture. To the extent that you can possible, look around and see what's already being collected so that you don't have to start from scratch. I will tell you that instrument design, that is data collection instrument design, takes a lot of time and extra effort. And so if you already have something that you can use, then that's all for the better. The second piece is really about to what extent are your learners truly captive? And if you are in a residency leadership position, or perhaps you are in charge of curricular scheduling, then take advantage of those elements that you have control over. Also, as a secondary point, is you may have groups that serve as natural comparisons. Perhaps you've not previously had a QI curriculum, and last year there was a needs assessment that was performed that showed the significant need for it. There you have a historical control and an intervention group. The last thing is, nobody does educational evaluation in a vacuum, so take advantage of the team members that you may have in front of you. Those that have statistical expertise are especially helpful. This may be someone who does biomedical statistics on the side or has some familiarity with survey design. Then champions, whether that's your program director or your vice chair for education, whoever you have that's around you that has some power and whose buy-in that you can get, that will help you, help grease the wheels for the educational project you have. perhaps be able to lend to you the kind of resources that are needed to develop educational evaluation. And of course, time. It is very hard in the life of a busy clinician to do this, especially if you're not getting protected time for it. And so recognize that time is probably far and away the most important resource that you need in order to embark on this area. I want to dive a little bit into study design options. As I mentioned, these tend to be much more your easier forms of study design. I have included, for instance, randomized controlled trials, but recognize that those tend to be the minority of study designs used in medical education. So I'll just go through one by one at some of these basics. The post-test only study design means essentially that you are delivering your curriculum and then asking perhaps on a survey or a knowledge test what they thought about the curriculum compared to how they felt before. A classic post-test only question might be, compared to before the curriculum, how much did you know what root cause analyses did? They are very easy to administer because you're only essentially capturing the learners once to do a survey. However, as you can imagine, people come into the curriculum with differing baselines of how much they know about the topic. And secondly, you generally will get an issue where people like to think that they gained something out of time that they invested in. And so the results from that kind of question tends to be, yes, I feel much more empowered to do RCT, root cause analyses because of this. And so there is a positive recall bias that normally evolves out of a study design like this. The second study design, and I would say this is far and away the most common one, is the pre-post test study design. This, as you can imagine, means that you deliver an instrument before and then after. It might be a survey collecting attitudes. It might be a knowledge test. The nice thing about this is that you can do controls for baseline. So if somebody comes in with high levels of attitudes about QI and patient safety, then they can serve as their own internal control when you measure them again after the curriculum. It generally detects change. I, for one, have only once encountered a curriculum that did not show that somebody learned something at the end of it. At the same time, you should recognize that it is not saying much that once somebody goes through an experience that they learned something. So to take a mundane example, if, for instance, I know no Russian words and you teach me 5 Russian words as part of a curriculum, my post-test scores will show that I've learned these 5 words. In the literature, it's really hard to publish simply about a statement like that you've learned a couple of words. The disadvantage of pre-post test design is what represents the true sample size. So essentially, if I get everybody to do a pre-test, but my post-test gets 5 responses, then my effective sample size is essentially 5. And the trouble with that is you put in so much effort to collect data that many of them fall out as a result of attrition, and therefore your sample size kind of plummets. So you do have to put just as much energy into collecting post-test data as you do pre-test data. This one, delayed post-testing, is essentially trying to measure skill decay. It can be layered on top of a post-test. That's the most common use of this. And what it does is measure something a little bit more meaningful, not how quickly was I able to remember exactly what you told me 30 minutes ago, but in 3 months or 6 months down the line, how much do I remember, how much do I use? And so it is one of the study designs that tends to be easier to publish, mainly because journal editors do care about these meaningful outcomes, such as how long did that knowledge stick with you. There's, again, the risk of subject attrition, especially once you have residents or medical students that sort of rotate off. It is harder to track them down. There's also the risk of having the skill completely disintegrate. And so you may have shown that in your immediate post-test, you had gain in knowledge, but then 3 months later, it all went away. Therefore, you have a negative result study that may not be easily publishable. I mentioned earlier that historical controls is a great opportunity to have a comparison group. For instance, if you're putting in a new curriculum, perhaps at the very end of the year, you could measure knowledge on that topic at the very end of the year and then compare to your next year when you've implemented your curriculum. Again, some of the disadvantages to it is that there may be things that have changed from last year to this year that had nothing to do with your curriculum. And so secular trends can play a role in this. And the other thing is sometimes it's really too late to collect data from historical controls. So to some extent, it really does require an existing data set. Randomized controls are controlled trials are very hard in medical education for a variety of reasons. It is hard, at least in our learner groups, to separate them completely. So the risk of contamination of information is very high because the residents or the students or even the faculty may talk to each other. There are also ethical concerns about giving one group a curriculum that another group has not been exposed to. And so your IRB may have issues with this. One way that I've gotten around that is by delivering the curriculum to the other group at a later time, or perhaps doing a crossover study. However, the strength of the RCT is as it would be for clinical research, in that things that you did not count for, things that you're not measuring, are taken care of by the randomization process. And it is considered a gold standard comparison in terms of a study design. I again encourage you to ask any questions in the chat, which I can see here. The third question is, what are the questions I hope to actually answer from my evaluation? What is it that I care about? To say that one strong educational principle is everything comes down to your goals and objectives. This is particularly true for evaluation. Your objectives should be written in a way that allows you to easily come up with your evaluation. In writing an objective, it should be specific, it should be measurable. I use these types of questions to ask myself, is this a good objective? So who is doing it, and what are they doing, and by when? So to take this to the example we've been using, the good objective might be at the end of this curriculum, radiology residents will be able to define core QI concepts by the end of the session. Define who will do what by when. As you can imagine, this easily facilitates the evaluation. I can then go on to design an evaluation that at some point will have the core QI concepts. I am an assessment person, so I use frameworks a lot. I find them to be especially helpful in an intuitive way to make sure that I've covered my bases when I think about evaluation. There are so many frameworks that one could use, and I'm just going to talk about the most common ones used in medical education because I don't want to overwhelm you with too much information. So the first one is KSA. This is also known as knowledge, skills, and attitudes. The nice thing about KSA is it's very intuitive. To take this back to the example of the project that we're using, knowledge is really head, it's the brain. So an example of an objective or an approach to evaluation that is based in knowledge would be that the resident is able to describe a root cause analysis. A skill objective or a skill approach to evaluation would mean someone who's able to actually conduct the root cause analysis. This takes it up a notch. It's not just knowledge, but knowledge application. And then lastly, don't forget about attitudes. This kind of soft skill might be overlooked sometimes, but it really does matter whether your residents care about the topics that you're trying to teach them, and it helps to collect this kind of information as satisfaction within your project. Another framework that you may or may not be familiar with is Miller's Pyramid. This is an approach to assessment that allows you to think about different levels, degrees of measurement. So the very baseline one is nose, and that is often tested by a knowledge test where you're asked to essentially regurgitate information. The next level for knowledge is knows how, so application. Methods like short answer essays may be able to get at this pretty well. The next level is shows how. Simulation, for instance, having the residents go through a simulation and asking them to report a patient safety event may be an example of how they take the knowledge that they have and translate that into actual behavior change. This is the kind of thing we really care about. It's not how they answer questions on a test, but what they will do. And then finally, does is in the realm of real-life clinical practice. So will residents, once they go back to the workplace, actually enact some of the principles of QI and patient safety that you taught? Miller's pyramid is really founded on increasing levels of authenticity. And the third and last framework that I'm going to show you is the one that I use the most when I think about evaluation. Kirkpatricks Levels of evaluation is essentially used in many different industries, including the business industry, to think about how we measure overall effectiveness. At the very bottom, I would say that learning and reactions are in the cognitive realm, and the other two are about behavior change. You can see that there's a lot of overlap with Miller's pyramid, but I find that most people do know about Kirkpatrick's levels of evaluation, and it's a little bit more easily intuited than Miller's pyramid. So again, reactions. How satisfied are the learners? That can be gleaned through results of a survey. The second level is what knowledge or skills have they actually learned? And so you could test this using knowledge tests or perhaps a simulated model. Behavior change, and it's just as a reminder, Kirkpatrick's levels of evaluation is defined such that the top two levels are in the workplace and the bottom two are sort of in the laboratory, in sort of testing areas. So to what extent do the residents enact new behaviors as a result of the curriculum? This might be gleaned by auditing the medical chart. And lastly, impact is the pinnacle of Kirkpatrick's levels of evaluation. And in medical education, that is always clinical outcome. Again, Kirkpatrick's levels of evaluation have a lot of overlap with Miller's. And I would say the construct that I think of how it differs is about meaningfulness of those results, where obviously we care most about the clinical impact. That being said, most educational projects really dwell in levels 1 and 2, simply because it's very hard to have the sample size to show behavior change and impact. Additionally, it just takes an additional level of mechanisms to measure this. Just as an aside, a journal like Medical Education or Med Portal or Academic Medicine, they tend to accept publications in the arena of level 2 or 3. Med Portal will accept submissions that are level 1 or 2. I think we're on question number 4, which is what can I use to measure these outcomes? This question really gets at what are the measurement tools that are available to me to get at this information. There are a lot of instruments, and it's, again, not necessary for you to know all of them. But the most common ones are, as you can imagine, surveys. Surveys to collect information about attitudes or experience or demographic information. So far and away, the most common use of measurement instruments to show change. Knowledge tests are also common. I would say one thing that surveys have as the bottom line issue is that they are based on self-report. And so there will be bias that is built into asking somebody questions about how much do they care about patient safety and QI. Knowledge tests are intended to get a little bit more objective information. Many knowledge tests are using multiple choice questions. The tricky thing about knowledge tests is it is not easy to create MCQs. I know I myself struggle with it. Writing a good question that is clear, coming up with multiple choices that don't have obvious correct answers. There's something called the Gold Book that is put out by the National Board of Medical Examiners. They're the ones that write the USMLE test. That might be a good resource. It's essentially what I consider the Bible of making multiple choice questions. That might be an important resource for you as you embark on writing knowledge test questions. Even lower on the list might be behavioral checklists. A prime example of how these checklists are used are in the simulation realm. Perhaps you've already codified a list of the critical actions that you need to see in a particular simulation, such as running a code. And so this is also a relatively objective form of collecting data. Lastly, focus groups is the source of qualitative information. We've focused a lot on quantitative information above, but focus groups can be really meaningful in terms of determining whether there are rich themes, better understanding of why residents have particular perceptions. Focus group data are usually collected by having the transcripts of that focus group put through a qualitative analysis process. So it is not low-hanging fruit, but it can glean very meaningful information. I've added a couple of other random common measurement instruments, but I would say I don't tend to use things like interviews, oral exams, or portfolios as much. If you get familiar with how to create a survey or how to put together a knowledge test, then you've covered your bases for most educational evaluation procedures. I'm now going into a little bit wonkier topics about measurement. And the threat to validity is something that assessment people worry about all the time. I need to make sure that the instrument that I'm creating actually gets what I'm after. So these are what I think of as the necessary and sufficient criteria for meaningful measurement. You, of course, want to make sure that you have an adequate sample size. Sometimes you don't have any choice about that. Let's say you have a residency size that's very small, or a medical student class that is fairly small. There's not much you can do about that, but sample size does play into how likely quantitative results are to show a statistical significance. The quality of the instrument is, I think, a theme that keeps coming up, is I need to make sure that the questions I write for my survey are getting at what I want, and I'll talk a little bit more about what are the elements of a high-quality instrument. And then bias. A lot of these data derive from human people, or humans, and so human factors, built-in biases about not wanting to report negative results, other systemic forms of bias can play into this. So if you've thought a little bit about your sample size to the extent that you can control it, put a little bit of effort into developing an instrument that is high quality and trying to mitigate the bias, then you will have meaningful measurement. I want to talk briefly about surveys and the issues that are attendant, the challenges that are attendant with surveys. The response rate is mitigated by many different factors, as you can imagine. One of them is format. Online versus paper, lock them in a classroom, or have them do it on their own time. All of those things, as you can imagine, play into survey response rates. I would say that I do not have as much luck with online surveys as I do with paper-based ones that are given at the very end of a session. That being said, some people prefer the ease of an online format. So something that you have to make trade-offs about. The second thing that plays into response rates, especially for surveys, is the topic itself. If it's a topic that people care a lot about, an example I would say is burnout and wellness. I have very high response rates to my surveys among residents about burnout. Then that can play into their willingness to click on the link and go there and complete all the questions. So to the extent that you can, you want to make the survey compelling in its topic. As you can imagine, being yourselves people who do surveys all the time, the longer the survey, the more likely people are to get survey fatigue and simply fall off of the survey. I've certainly gone through a survey and after 5 questions decided I didn't want to invest any more time in it. So do think about making the survey as short as you can possibly get away with. Something related to length is cognitive load. The reality is we have overwhelmed brains and we're being pulled in so many directions. A survey that asks complex questions and has very long phrases is asking you to rank 20 items in order of preference. Those are high cognitive load surveys and definitely at risk for drop-off in terms of your respondents. Think about having somebody look through your survey and make sure that it's easy to read, easy to understand. Don't overlook the fact that matrix-type questions where you have maybe agree, disagree, neutral in a table as opposed to brought out as separate questions can decrease the cognitive load of a given survey. This is something that I think a lot about, and sometimes the only way I can get information about the load of my survey is by asking somebody else to pilot it. Repeated measurements. This really plays into response rate when you think about pre and post test questions. I find that many residents or trainees are willing to do the pre-test knowledge test the first time, but the second time they may be a little bit less willing. So recognize every time that you try to measure something, you may have attrition and fall off, and that will obviously affect your response rate. Lastly, think about ethical incentives that you can build in to get people to fill out your surveys. Maybe it's a drawing for a lottery. Maybe it's attaching a piece of candy to the paper survey. I've tried that in the past. If you look in your mail, for instance, sometimes people have stamps or even dollar bills attached to those paper surveys. There's a whole science in market research about what are the kind of incentives that help people complete survey responses. One of them might be using first names instead of, "Dear respondent, please complete my survey." So this whole panoply of different factors plays into what your eventual sample size is going to be, and so it's something to think about. As it relates to instrument quality, there are two major domains, reliability and validity. I've separated them out, but in reality, validity has started to be recognized as the major thing, and reliability as a subset of validity. That being said, I'm going to describe them separately just to make things a little bit clearer. So reliability is about consistency or reproducibility, whereas validity is, are they actually measuring what I want? So for instance, when we think about reliability, there are controllable factors. To what extent does somebody look at my instrument and use it the same way that somebody else does? That's instrument variability. There's also observer variability. So if I'm using a checklist for an OSCE or to grade a simulation, to what extent will Dr. X use it the same way that Dr. Y did? Those are sources of variability that you can control making an instrument as clear and as specific as possible. There are, however, uncontrollable factors in reliability. How one student performs compared to another is something that's out of your control. So to the extent possible, try to create an instrument where you think that most people will use it in the same way and understand the questions in the same way. This again enforces the importance of having it pilot tested by people so that you can anticipate what kind of misunderstandings people might have about your wording or how a question is phrased. Moving on to validity, it's really about accuracy. Does what you measure equal what you intend to measure? Something to think about is, since there's no gold standard valid instrument, all you're doing is collecting information that serve as proxies for what you really want. So for instance, while I do want my residents to know everything about QI and patient safety, my proxy is how they perform on a standardized knowledge test. Obviously, my test cannot be so long that it covers all the bases, and then that might not even be a realistic thing. So the question to ask myself is, to what extent are my 20 questions on my knowledge test really getting at full knowledge of QI and patient safety? Similarly, I want them to have the kind of skills that can allow them to be leaders in patient safety. So performing a root cause analysis one time or twice may get at this, but it's simply a proxy for the gold standard of QI and patient safety skills. Putting these things together, you may be familiar with this metaphor for what is reliable and valid. So the very first target there gives us what? Is it reliable? Is it valid? So it's reliable in the sense that you've gotten consistent measurements each time. Those arrows are hitting the same place, but it's not valid if you think about the bullseye as the gold standard. As you can imagine, the second one is both reliable and valid. You have consistent, reproducible results, and they are hitting the bullseye each time. And the third one is a little bit nuanced. Is this reliable? Is it valid? Well, it's definitely not reliable because you are not having consistent targets in the same place. And then even though it seems to be sort of centered around the bullseye, because it's not reliable, it's not valid at all. So the idea of something that is unreliable but valid is really a misnomer because reliability is a necessary element of validity. We then move to talking about measurement biases. And I talked about this earlier because we're simply human and we don't have a completely objective view of the world. So it's being aware of some of the biases may help you try to get your instrument more valid. One category of bias is inadequate sampling, and the other one is rater bias. So examples of inadequate sampling, this essentially means that you're trying to understand what the whole population of residents are doing. However, you are probably only going to get a subset of those residents to complete your survey. So there's a selection bias, perhaps for especially diligent residents or residents who care about the topic. And that's a form of inadequate sampling. You have no data from the group of people who did not do your survey. A different form of inadequate sampling is something called content underrepresentation. I mentioned earlier that 20 questions on a knowledge test is not going to cover everything in patient safety and quality. And so you need to make sure that you're balancing how much of the knowledge test covers those concepts versus not wanting to tire them out because you have a 100-question knowledge test. And so sampling is definitely an issue in this. These are biases that you will all be familiar with. Leniency bias relates to grade inflation. You know this whenever you complete an evaluation on a trainee, is that it's really hard to fill out something that is on the left-hand side as poor or needs improvement. Everyone is subject to the Lake Wobegon effect in that residents are, we really want to give them higher grades. The halo and the horn effect are two sides of the same coin. The halo effect relates to the fact that how you globally see somebody will affect how you specifically rate them. For instance, if I have a very likable resident, then I will give them great scores in all of their competencies without thinking about how they might be performing specifically in communication or professionalism. The horn effect is simply the opposite of that. Someone that you may not like will get low scores across the board. A word on research ethics, which is really equated to IRB. I have moved a lot since my previous history as someone who was a hater of IRB and have realized that it actually is a very powerful companion as I do educational evaluation. For one thing, the IRB forces you to write down the purpose and the background, the methods for your section, and so it forces you almost to submit something that resembles a mini grant proposal. It reminds you about important things like confidentiality of your data and informed consent, making sure that your subjects are volunteers and that their rights as human subjects are not being violated. The other thing is that it serves a really nice background and outline for publishing a paper because you already essentially have the intro and the methods section of your manuscript pre-written when you do the IRB. So I do think about making it count twice and putting the extra effort into doing a thoughtful IRB application. Whenever you collect data from humans, it is important to get an IRB. I think the days have gone by where we thought we could collect a lot of data about sensitive information without getting an IRB. Nowadays, I would say my first thought is I need to apply for the IRB, and it just keeps you safe many journals these days will actually ask for documentation of the IRB before they'll even review your manuscript. So it serves you well to think about the IRB. The last section is where I get the wonkiest, and this is going to feel, no matter what, faster than you can absorb. The slides, I think, will be available to those who have attended this. And this is just a brief way to familiarize yourself with the fact that you have the tools at your disposal to do simple analyses of data. So very briefly, there are two categories of statistics. Descriptive is simply, as you can imagine, just a description of the data that you have. You're not trying to make any value statement about the data. You're just saying 50% were female, 6 of them were of this age, 20% of them were from the South. Inferential statistics, however, are what we usually think of as statistics. These are the ones that are associated with tests of equivalence, namely tests that have p-values associated with them. In order to have inferential statistics, you have to have a comparison group. It might not just be 2 groups, it might be more, but the comparison is really what is involved in an inferential statistical approach. There are 3 large categories for variables. The first is called interval. And one thing that doesn't help with these names is that they're not very intuitive, but interval variables are essentially the continuous and numeric ones. Categorical variables are ones that fit into categories, male, female, yes, no. And then there are ordinal variables. These might look like interval variables in that some of them are associated with numbers, but they're ordered and not continuous. A great example of an ordinal variable is strongly disagree, disagree, neutral, agree, and strongly agree. So to give some examples, age is generally a continuous interval variable. If I depict age as ranges, for instance, less than 25, 26 to 30, then those are actually categorical. That can be confusing because the data come in as numbers, but because you're grouping them as ranges, they are categorical variables. And then ordinal is training level, PGY1, 2, and 3. Those are not continuous, but they have some kind of rank order specified within them. And as I mentioned, agree, disagree, those kind of scales are ordinal variables. And the reason why classifying your variables matters is because that is what tells you what kind of test of significance that you're using. I'm only going to cover the first 2. T-test, which you may remember from the cobwebs of the college stats course, is associated with those continuous variables, whereas the chi-squared, that 2x2 table, is associated with categorical variables. I'm not going to talk about Wilcoxon rank sum, also known as Mann-Whitney-U, but those are tests that are used for ordinal variables. So I'm going to very briefly go to the real world and hope to finish up on time. What I'm going to show you now is an example data set from the project that we've been talking about. Hopefully you will see here my Excel spreadsheet. This survey involved only 8 people, so it's not likely to show significance, but I did want to show you what it might look like to run some tests on these data. You can see from the first column that we have age. That is an interval variable. The second question about whether they think QI is essential is a categorical variable. And the third one is a ordinal variable, so whether they thought the curriculum was valuable. So in terms of doing statistics, descriptive statistics, I'm going to make the screen a little bit smaller here and hope that you can see it. We can make some calculations about the age and whether they think it's essential or not. I'm going to start with the easier question. There are, again, out of the scope of this, easier ways to manipulate this in Excel, but I'm going to do it in the simplest way form. So I'm simply going to count that there were 5 responses to this question that were yes, and 2 responses that were no. And I've already counted wrong. I'm sorry about that. 6 and 2. You could go on to provide the percentage of 6/8 and 2/8, and I won't do that right now. And then, again, these are descriptive statistics, is what is the average age. And in Excel, there are easy functions that you can use to calculate this. So very quickly, I will do this. And that gives me an average of 30.1 years. And similarly, there is a standard deviation formula here. Again, I recognize I'm going through this very quickly. I just want to give you some familiarity with what your test can do. And so I've completed my descriptive statistics right here. I've given the average age and standard deviation for my interval variables, and then I've also given some data on description on my categorical variable. I'm now going to move to inferential statistics and then, again, make my screen slightly smaller and hope for the best that you can see this. So my question for inferential, my first question for comparison is, do residents who think QI is essential think that the curriculum was valuable? I'm going to simplify this and essentially transform this variable, which was an ordinal variable, into something that's categorical. I'm going to say that everybody that agreed or strongly agreed is in one group, and everybody that was neutral, disagree, or strongly disagree is in another group. I would say, in general, with Likert-type questions like this, this is the best practice, is to treat these as categorical variables rather than treating this as a 4, and this is a 3, and this is a 5, and then taking the average. Simply because I can't say that the distance between agree and strongly agree is the same as neutral and agree. And then I'm going to look at those groups of people that thought QI was essential versus those that were not. So as you can see, this is a comparison that results in a 2-by-2 contingency table. So in total, the number of people that thought QI was essential was 6, and those that did not was 2. And those that agreed that the curriculum was valuable includes 1, 2, 3, 4, 5, 6 people here. And those that were neutral or disagreed was 2. And then I need to look to complete my 2-by-2 table. I need to look at the subset of those that agreed and thought that QI was essential. And for me, that number is 1, 2, 3, 4, 5 here. And there was one person that thought that the curriculum was valuable, but did not think that QI was essential. And then the number of people that thought it was valuable, but then did not think that QI was essential was 1 here. I hope I have these numbers right. I'm trying to think of this on my own. And then I think we have 5 here. Oh, sorry, 1. And then what I do is go to a website, and you can do a quick Google search for online chi-squared test and essentially get something like this. I happen to use GraphPad, but there are many, many that don't, that can work for you. And then I plug in the numbers. As you can see, these labels mirror what I had in here. And I can just see it's 5 and 1 and 1 and 1. And I essentially plug in those numbers. I really do hope I have the right numbers in here because I did not have some time to think about it. I always do a two-tailed test. That means I'm interested in either direction for it, and then I hit calculate. This gives me a chi-squared p-value of 0.3458. And as you can imagine, given our small numbers, we were not likely to get statistical significance between these two groups. But it does generate the p-value that you're interested in. So that's an example of how you can create a chi-squared test based on that simple question. You can do the same thing, and just for the purposes of time, I won't go through this. But let's say you were asking this relatively artificial, contrived question about whether residents who think QI is essential are different in age than those who don't think it's essential. Maybe your hypothesis is that older residents think that it's not essential, where their younger residents think that it is. And there you would go back here and take the average age of the subset of residents that thought QI was essential versus those that did not. Getting the average, the standard deviation, and the total number in each group, plugging that into something that comes up when you Google online t-tests will allow you to plug these things and give you a p-value. So again, I know I've gone very quickly through this, but the hope is that you can see using something that's on your fingertips like Excel and Google for online statistical tests can allow you to generate the kind of p-values you may need for your educational project. And then moving back to my slides, I want to go back to the educational project that we talked about in the very beginning. So how might I actually approach evaluating a curriculum to teach QI and patient safety to radiology residents? Like I said, Kirkpatrick's level of evaluation is what I tend to use for thinking about evaluation. Reactions, learning, and behavior represent the levels 1, 2, and 3 of Kirkpatrick's. And so here are some ideas. I would do a survey to make sure that they liked the curriculum in the first place and to get their baseline attitudes about QI and patient safety. I would use this as a pre-test. Secondly, I would do a knowledge test about learning. It might mean, please define adverse event or near miss. I might also include short essay questions that ask them about knowing how to apply the knowledge they have. Behavior, of course, is harder, and I'm not sure if I would actually do this in reality, but one way to measure, to evaluate this project is to get them to do an RCA, a root cause analysis, and to create a grading scheme that you can use to measure the quality of their RCA. And perhaps as part of the curriculum, I want them to do a project. And so seeing the project come to fruition might be an example of how they've meaningfully applied the QI and patient safety concepts and changed their behavior as a result. I am kind of pessimistic that anything I do is going to result in clinical impact, so I'm going to suffice with levels 1, 2, and 3 of Kirkpatrick's. And lastly, the study design that I could take for this would be a pre-post design. This allows me to normalize for baseline attitudes and knowledge about patient safety and quality. And then perhaps I'm going to use historical controls. Maybe I have data from a previous years of residents that have done some kind of assessment of their patient safety and QI understanding. So to sum up, a series of questions are necessary to answer when you think about evaluating an educational project. Thinking about why you're doing what you're doing, what's actually low-hanging fruit, the questions that you want to answer, what tools you're going to do and create to measure these outcomes. What are the things that are going to throw me off in terms of coming up with conclusions from my evaluation? And then lastly, how do I analyze my data, or how might I approach somebody who has some statistical knowledge, have them help me with my project? These are resources that I've used over the years to learn about educational evaluation. The first one is essentially we think of as the gospel for curriculum development in medical education. Many of the things that I talked about today are in there, including the questions that are used for evaluating your educational project. These other books are really helpful. This one is about scales, and then this last one is one that is not in the medical literature, but is essentially best practices in creating survey questions, which may be part of a lot of your projects. I hope that people are not completely overwhelmed and have too many questions to be answered. I am available. RSNA knows how to reach me if there are any questions moving forward, and I very much enjoyed the opportunity to talk to you today.